Yeah, so that is that. So now I have a problem. Okay, let me just, yeah. Okay, so yeah, let's start with the usual stuff, which is terminology. Amenorrhea really is lack of menses. That's the basic definition, that we have a woman who's not having her menses. Having said that, there is what is called clinical amenorrhea. Clinical amenorrhea means that you have a problem, which is that there are no menses, which needs medical attention. So that's how I differentiate those two. Amenorrhea is just simply absence of menses, but we have what I call clinical amenorrhea, which is that you've decided that the lack of menses is a problem and it needs to be attended to. So if somebody has been having regular menses, and again, going back to when you people have those exams where we're asking, define amenorrhea. So amenorrhea is different. If you have been having regular menses, you need to have 3 months of no menses for us to really call it like a problem, a clinical amenorrhea, something that needs to be attended to. If you have been having irregular menses, we only say amenorrhea when you have been having, if you have been having irregular menses, we only say amenorrhea when you haven't had periods for 6 months. So you can see that just the word define amenorrhea has like, if you just say amenorrhea is lack of menses, it means that if that question, that definition has 4 marks, or let's say usually the case is that it has 2 marks, it means that you only get half in that answer, because you haven't indicated that in somebody who has regular menses, we define it as lack of menses for 3 months. And in somebody with irregular menses, we define it as somebody who has no menses for 6 months. So you've lost all those points in your definition. So you end up having half instead of 2, because you only said lack of menses. But lack of menses is not technically what we mean when we say amenorrhea. There's more to it than just absence of menses. That is clinically. So that is what it is. Then you have primary amenorrhea. Again here, some of you will just say primary amenorrhea is menses in somebody who has never had menses before. But there's a lot to that definition. There is lack of menses in somebody who's 16 years old, and lack of menses in somebody who's 14 years old. So if you are 16 years old, if you, let's say, if you have secondary sexual characteristics, this girl has breasts, she has hips, she's growing like a female, but only menses haven't come. So if she has, meaning that she has secondary sexual characteristics. So if she has secondary sexual characteristics, we wait until she's 16 years old before we can say there's primary amenorrhea here. In a girl with no secondary sexual characteristics, we say primary amenorrhea has been diagnosed in this girl if she has no secondary sexual characteristics. We diagnose primary amenorrhea when she's 14. So when we ask what is primary amenorrhea, all those have to be mentioned. That it's absence of menses by age 14 in somebody with no secondary sexual characteristics. It's lack of menses in somebody who's 16 if they have secondary sexual characteristics. So if you just say primary amenorrhea is lack of menses or menses not starting, you end up with half instead of ending up with 2. Then secondary amenorrhea is the simple one. It's lack of menses in somebody who has had menses before, and it's what we're describing at the beginning. It's like the thing we're saying at the beginning. Secondary amenorrhea is really just absence of menses in somebody who has had menses before. So it's lack of menses for 3 months in somebody who has had regular menses, absence of menses for 6 months in somebody who has had irregular menses. So you need to be comprehensive when you answer these simple definitions, because you end up getting half instead of 2. And then you say that, no, the definitions were easy, I knew them, but then you didn't complete the definition of these terminologies. I hope that is clear.
Dr. Chanzi, may you please repeat amenorrhea on its own?
Amenorrhea is just lack of menses. But the problem is that when we ask as a definition, what we are, so if somebody says amenorrhea, what you should define is like secondary amenorrhea, which is absence of menses for 3 months in somebody who has had regular menses, or absence for 6 months in somebody who has 6 months in somebody who has had irregular menses. But the basic definition is just that absence of menses. That's the basic definition. But you need to be careful about when it's asked for as a definition. You need to be clear. Is it primary you are defining? Is it secondary amenorrhea you are defining? That's what I'm saying.
All right.
Yeah.
All right, thank you.
And for the sake of marks, when they say amenorrhea, I would advise that you define it like secondary amenorrhea, which is what we've talked about. Lack of menses for 3 months in somebody who has had regular menses, and lack of menses for 6 months in somebody who has had irregular menses. That's really what amenorrhea is by itself. So you define it like a secondary amenorrhea. Primary amenorrhea, you have to remember that you have to put the 14 years age and you have to put the 16 years age in your definition. Yeah, so that's important, because I see that that's where somebody gets half instead of 2. And if you have 20 definitions, each of them is 2 marks, it's 40 marks. And if you keep getting half, you end up, each of them is 2 marks. So if you get half, it's half times, I don't know, you end up with 10. Yeah, you end up with 10 out of 40 instead of 20 out of 40 or something, because now you're getting half instead of getting the whole thing. So we know that amenorrhea can be pathological or it can be physiological. So we know physiological means what situations are normal to have amenorrhea. So what we are defining on the other side is kind of like pathological amenorrhea. But there is physiological amenorrhea. Physiological amenorrhea means amenorrhea that is not due to any pathology. So pregnancy, you get physiological amenorrhea. Before you attain menarche, you're not having menses, because that's physiological amenorrhea. Menopause. Menopause is achieved around 51 years of age on average. We say you have early menopause if the menopause starts before 45 years. We say you have premature menopause when the menopause starts before 40 years. So menopause is a physiological state that you can have amenorrhea. Then lactation as well. We have what is called lactation amenorrhea, which is when a woman is breastfeeding exclusively, usually, they will have amenorrhea. Because when you are breastfeeding, you have hyperprolactinemia. Hyperprolactinemia causes an ovulation, it causes amenorrhea. That's why breastfeeding is a method of contraception, exclusive breastfeeding. Because if you breastfeed a lot, you have hyperprolactinemia. Hyperprolactinemia causes an ovulation. An ovulation causes amenorrhea. So that is that. So pathological amenorrhea, which is what we're defining, can be caused by different things. The problem can be in the hypothalamus, can be in the pituitary gland, it can be in the ovary, it can be in the uterus itself. Yeah, so that is about the pathological amenorrhea. So this is like a list of causes of amenorrhea or pathological amenorrhea that has been caused because of problems in the hypothalamus. What you need to recognize about this list here is that it's really a list of stress. Any stress, the hypothalamus is very sensitive to stress. So any kind of stress causes the hypothalamus not to produce gonadotrophin releasing hormone in a correct way. That causes the pituitary gland not to produce follicle stimulating hormone, luteinizing hormone. That eventually causes the ovary not to produce the ovum. So it causes an ovulation. So you need to look at these things as stress. Being overweight is stress on the body. Being underweight is stress on the body. Chronic illness, sport, change of environment, dieting, that is stress on the body. All these things can, on the hypothalamus, all these things can cause amenorrhea. And this amenorrhea is from the hypothalamus. Then you can have a tumor in the hypothalamus, a craniopharyngioma. You can have what is called Cowman syndrome. And this is one of the questions we normally would ask in your MCQs, which is that you see a girl with who's admitted, they have no smell and they have amenorrhea. What's the diagnosis? The diagnosis is Cowman syndrome. Cowman syndrome is a syndrome because you know, the hypothalamus and the olfactory bulbs develop from the same place embryologically. So when there's a problem with hypothalamus, usually there'll be a problem with the olfactory bulb development, and a girl will develop with no sense of smell, but they also have an underdeveloped hypothalamus. So that is what is called craniopharyngioma, or that is what is called the Cowman syndrome. So you have a lack of sense of smell, and amenorrhea is equal to Cowman syndrome. That's a common multiple choice question. So that's about the hypothalamus. All you have to remember is stress. And the second thing you have to remember on hypothalamic causes of amenorrhea is Cowman syndrome, because it's, like I say, it's a common, you have to put it in red. It's a common MCQ question that is always there somewhere in your MCQs. Then you have amenorrhea that is as a result of problems with the pituitary gland. So you can have a pituitary tumor. You can have a pituitary tumor that destroys the pituitary gland, and therefore there's no follicle stimulating hormone being produced, there's no luteinizing hormone being produced, and therefore this patient won't ovulate. They will have amenorrhea because there's no follicle stimulating hormone and there's no luteinizing hormone. Again, a common MCQ question is this Sheehan syndrome. So Sheehan syndrome is also a definition that we ask about a lot. You need to know what Sheehan syndrome is, which is the fact that you have had postpartum hemorrhage. And we know that the anterior pituitary gland does not have its own blood supply. So it borrows its blood supply from the posterior pituitary. So when there's postpartum hemorrhage, it's affected. When there's hypotension, there's little blood flowing to the anterior pituitary because there's a portal system and the blood flow in the portal system is very sluggish. So when there is postpartum hemorrhage and hypotension, the anterior pituitary is the one that is affected most. And then you end up with this patient who has this condition of amenorrhea after a postpartum hemorrhage. These patients will normally present with failure to breastfeed, because in the anterior pituitary, that's where prolactin is also produced, and prolactin is responsible for production of milk. They might present with loss of body hair, because growth hormone is produced in the anterior pituitary, and if the anterior pituitary is damaged, that growth hormone production is reduced. So they can present with all those things. So you need to be aware of somebody who presents with failure to breastfeed after a postpartum hemorrhage. The diagnosis is Sheehan syndrome, or lack of menses after a postpartum hemorrhage. The diagnosis is Sheehan syndrome. So that is about Sheehan syndrome. Then you might have a problem in the ovary itself. So these are like primary ovarian pathologies. So you might have premature ovarian failure, you might have polycystic ovarian disease, and you might have someone with no ovaries at all. Sometimes drugs, methotrexate, a lot of cancer drugs end up destroying the ovary. Sometimes it's somebody who's post-hysterectomy. We know that if you have a hysterectomy, ovarian failure is likely because blood supply to the ovary might be disturbed and things like that. So it might be surgery as well, or ovaries that have been removed because of them having a pathology. So these are ovarian pathologies. I always say sometimes you always have to think about the possibility that it's a man in front of you. So sometimes you have a person in front of you and they're actually a man. They are XX, they are XY. But the problem is that when you look at their morphology, they have a vagina, they have a vulva, and you think it's a man, where it's a woman when it's actually a man, like in the condition of androgen insensitivity syndrome. You have an XY person, and they have a testis, but the tissues don't respond, or fail to respond to testosterone. So they develop a vulva and a vagina instead of a penis and scrotum. So when you look at them, you think that it's a male when it's a female when it's actually a male. So that's what androgen insensitivity syndrome is. Yeah, so we've talked about hypothalamic problems, we've talked about pituitary problems, we've talked about primary ovarian problems. Now we are talking about problems with the uterus itself. Somebody might have an imperforate hymen, somebody might have Asherman syndrome. And again, Asherman syndrome is something that we ask about a lot in your MCQs, which is that somebody has maybe an incomplete abortion, then there is overcurating of the endometrium, a D&C is done, and they end up with fibrosis of the endometrial lining and amenorrhea in the end. So D&C, if you see in the multiple choice questions where you have a D&C and you have amenorrhea, the answer is Asherman syndrome, because Asherman syndrome is a result of overcurating using D&C very aggressively so that you remove all the endometrium there and the patient ends up with amenorrhea or hypoamenorrhea, meaning that they're just bleeding very little during their menses. Sometimes there's no uterus congenitally. There's what is called Mayer-Rokitansky syndrome. Again, you have to remember that syndrome. It's called Mayer-Rokitansky syndrome. It's a congenital absence of the uterus. So that's something you see in your multiple choice questions as well as a cause of amenorrhea. What happens is that those Mullerian ducts don't form, and therefore the uterus doesn't form at all. So this patient has no fallopian tubes, they have no uterus, and so on. And that is what is called the Mayer-Rokitansky syndrome, congenital absence of the uterus. So evaluation really is you taking a very good history, because you've seen that there's a lot of things that can cause amenorrhea. It can be primary, it can be secondary. So you need to take a good history. You need to do a good examination. You remember that with primary amenorrhea, we only say primary amenorrhea if you haven't developed secondary sexual characteristics and you are 14, then you have primary amenorrhea. So you need to see, are these secondary sexual characteristics developed? Look at the breasts, look at the hair distribution, and all those things. So you have to do a good examination. You have to do a pelvic, a genital exam. Maybe it's somebody without a uterus. It's a male, like we've said. It's somebody who's XY and they have no uterus. That's why they are not having menses. They might have what we talked about, an imperforate hymen. Though the story in a patient with an imperforate hymen is that they are having symptoms of, like they're having menses, they're having abdominal pain every month, only that the bleeding is the one which is not coming. That's what the history of an imperforate hymen patient looks like. So you have to do a proper history, you have to do a proper exam, you have to do a proper pelvic exam, and so on, looking at all those features that we've talked about. Of course, you have to do a pregnancy test, because the commonest cause of secondary amenorrhea is pregnancy. So you have to do a pregnancy test. You have to do ultrasound, of course. You have to do all sorts of tests. You can do follicle stimulating hormone. You can do luteinizing hormone. It really depends on what you've decided in the history. You can do karyotyping, looking at the genetic makeup of this individual. You can do a CT scan. Maybe they have a craniopharyngioma, maybe they have a pituitary gland tumor, and so on. So the management of this patient depends on the cause of the amenorrhea. That's really what. Can everyone hear me?
Yes, Dr. Shansi.
Yeah, so the management really depends on the cause of the amenorrhea. Yeah, what has caused the amenorrhea? Then you can go on and you can talk about androgen insensitivity syndrome by itself and how it's managed. We can talk about Sheehan syndrome by itself and how it's managed. We can talk about Asherman syndrome itself and how it's managed, but it's not the purpose of this discussion. The other thing I see in the exams is that, you know, when you have a primary ovarian problem, your FSH, follicle stimulating hormone and luteinizing hormone, when you do your labs, is going to be very high. It's going to be high because the pituitary gland is trying to stimulate the ovary to produce follicles because the ovary has failed. So the pituitary gland is trying to produce more and more follicle stimulating hormone to tell the ovary to start working. So you need to be aware that if your FSH is high and your LH is high, then usually the problem is in the ovary. On the other hand, if your, let's say, the problem is somewhere else, is in the pituitary gland. If the problem is in the pituitary gland, it means that follicle stimulating hormone will be low and luteinizing hormone will be low. So if you do your test and you find FSH is low and luteinizing hormone is low, it means that the problem is either in the pituitary gland or the hypothalamus. So you need to be aware of that. So the terminology used for that is hypergonadotrophic hypogonadism. So hypergonadotrophic hypogonadism means that hypogonadotrophic means that FSH and LH is low. That's why we are saying hypogonadotrophic. So if FSH and LH is low, it means the problem is in the pituitary or it's in the hypothalamus. If you find FSH is high and LH is high, that is called hypergonadotrophic hypogonadism. It means that the problem there, like we've already said, is in the ovary. So the pituitary gland and the hypothalamus are trying to work to produce more FSH and LH to stimulate the ovary to work. So that's the other two terminology you are going to come up across. Hypergonadotrophic hypogonadism and hypogonadotrophic hypogonadism. So those are the two. So you just need to remember that if you have hypergonadotrophic hypogonadism, it means that FSH is like this. If you have the other one, it's like that. So that's the other last thing I think I can say about amenorrhea. Then I'll ask you to ask me some questions. So you remember that amenorrhea is a topic of syndromes. So you need to be aware of all these syndromes we've talked about, starting from the hypothalamus. We have Cowman syndrome, pituitary gland, we have Sheehan syndrome. When we come to the uterus, we have Asherman syndrome. Then we have androgen insensitivity syndrome. All those syndromes are common and you need to know about them because they are associated with amenorrhea and they are common multiple choice questions. So amenorrhea is a disease of syndromes. So we need to remember all those syndromes. Yeah. So any questions in the next 7-8 minutes? I don't know what's wrong with my my Zoom today because it shouldn't stop, but it's telling me that 9 minutes remaining. But anyway, you can ask.
Dr. Shanze.
Yeah.
For example, in a patient who has secondary amenorrhea, is counseling important? And if it is important, how do you go about with the counseling?
Yeah, so the question you're asking is important, but you need to remember that we have not covered specific diseases. So your counseling is important if we are discussing a specific condition, because let's say amenorrhea is because you are pregnant and you want to be pregnant. So the kind of counseling you have is different. If you have a tumor and that's why you're having secondary amenorrhea, the kind of counseling is different. You're counseling somebody who has a hyperprolactinemia, hyperprolactinemia due to a prolactin producing tumor. So the way you counsel really depends on the condition. That's why I've put at the bottom there that the management really depends on what condition are you dealing with. The kind of counseling you have depends on what kind of condition you have. But this is like a general amenorrhea lecture, so that if any question is asked on amenorrhea, I'm sure that you can pick it up what it is and answer, so that you don't struggle with amenorrhea as a whole. So that's the aim of this topic. But when you go specific to specific condition, then the counseling will be tailored to the particular diagnosis. Is it a craniopharyngioma? Is it Asherman's? Is it androgen insensitivity syndrome? These are completely different diseases, and the kind of counseling you have depends on the kind of disease that is in front of you. Yeah. I hope that is clear.
It's clear, Dr. Shanze. It's clear.
Yeah. So is there any other question? Any other thing that is not clear? Okay, if there's nothing, I think we'll end here. what I need to do now for you is that, okay, when we meet tomorrow, I'll try and isolate for you like an exam paper or something, and we look for the two conditions we've looked at. We look at some multiple choice questions quickly, maybe in 5 minutes, that have been set looking at these particular conditions, and then we can like discuss why this is an answer and why that is an answer, and then we can discuss abortions tomorrow, like what I call the abortion tree. That's what we are going to discuss tomorrow, because abortions are common and there are a lot of questions on abortions in your papers. So we'll talk about that tomorrow, and hopefully we'll look at some questions as well. Yeah.
Okay.
Yeah, there's no questions, right?
Okay, thank you very much.
Okay, so that's what I'll do today. I'll just organize maybe a few questions in the most recent past paper I have. I can look through and see questions that are related to what we've talked about. We see if we can answer them, and then we move on.
Thank you very much, Dr. Shanzi.
Yes.
It was very enlightening.
Okay, thank you.
Dr. Shanzi,
Yes.
the answering, is it going to be like, since we are just a few of us, like you test how we can answer as individually or what?
No.
No, not necessarily. We just discuss as a family.
discuss.
I can say, I mention your name. Okay, Melissa, what do you think is the answer and why?
Okay.
And then another person says what they think. If they think the same, they say why. We just discuss. It's like a learning process. Yeah.
Thank you.
If you want a test, I can set one for you separately. We find a venue, we try, we mark. That can be done separately. For this purpose, it's just us talking. Yeah.
We're going to appreciate that.
Okay.
Yeah,
okay.
even for the test later on, after we'll like cover
Yeah,
the
after we've done enough. Yeah.
Yes.
Okay.
Yes.
Okay, thank you so much.
Thank you. Good
Thank
day.
you.
Bye.